Hey, good afternoon, everyone. I'm Dr. Mitch Katz, and I'm very proud to be the director of the Department of Health Services. This is our second virtual town hall, and the feedback we got on the first town hall was that best part was people in DHS seeing other people in DHS at the different sites, which is part of why I think this is such a great technology. Right, I can come out to different sites as I do and meet individuals, but it's rare that people get to see their fantastic colleagues at different sites. And so I'm hoping that this will become a major tradition for us. Today's meeting is special because we're going to use it as a highlight the fantastic work that's been going on between our labor organizers in SEIU and the Department of Health Services. In so many urban health systems, people are wasting their time fighting with unions instead of recognizing the tremendous opportunity that we all have to work together for our common purpose. Under health reform, the most important thing is our ability to be able to maintain our patients, to provide great service so that patients want to stay with us. It's particularly important in Los Angeles because there are a large number of people who remain uninsured. And in order for us to have sufficient revenue to be able to take care of everybody, we need to be able to retain our patient base. We're very lucky that in Los Angeles we have a union that recognizes our common purpose and that is every bit as committed to fantastic patient service, to high worker morale. It's impossible to give good service, and I know this myself when I'm working in clinic. If I'm not feeling my best, I can't do my best for my patients. And I know that's true for all of us in our work. So having great morale when you're a health service provider is incredibly important. And so I'm so pleased, and I'd like to start by introducing Bob Schoonover, who is the president of SEIU Local.
Thank you so much. Good afternoon, everybody.
Good afternoon.
We're in a transformational time right now. We all know that. And partnering with LA County is both beneficial to the patients, to LA County, and to the members of Local 721 who provide the great majority of the workforce here providing services to the community. One instance, I think, which will illustrate how Mitch and I both view the importance of this project. Let's go back, I don't know, maybe it was a year and a half ago when the constitutionality of the Affordable Care Act was in question. We've been working at this process in the early stages, and I was having a phone conversation with Mitch, and I said, we're preparing for this, and what if they say that it's unconstitutional? I said, I think we're doing the right thing by finding ways to improve service and how we deliver health care to the community, and I think we should just keep going, don't you? He said, absolutely. What we're doing here, we're doing because of the Affordable Care Act, but it's really the right thing to be doing. We're changing the way that a lot of things are done more efficiently and effectively, but the outcome is, no matter what your client base is, we're trying to provide services in a better, more effective way. It's been my experience as a union leader for many years that our members really all want to do a good job, and if you're trying to improve the service in an entity, be it a hospital or whatever, the way that you do that is you get the people that deliver it on a daily basis together, and you include management in the process, and you talk about what are the pitfalls and how can we improve things. Because you all know the problems because you deal with them every day. So SEIU 721 is invested in this process, and we intend to see this hospital system succeed.
So, good afternoon, everybody. My name is Gilda Valdez. I am the Chief of Staff for Local 721, and I can't tell you how exciting today is for us. This is the first time, actually, that I've been engaged at this level in a partnership. And it's really, it just comes from the point that if we don't come together with the employer, with Mitch Katz's leadership, with Bob's leadership, and really work with our rank and file in a different way to do this work, we can't succeed. And it's really real. I've been, for all of these years, all of my life, I've been a real fighter, and but, you know, never afraid of an adversarial fight with an employer. But we're really talking about survival. We're talking about whether we're going to be able to develop the quality health system for Southern California that really allows us to not only survive but provide the best patient quality care for everybody, for our communities. And so for us, it's our responsibility to engage in this process at every single level possible. And I think the beauty of what's happening in this partnership is that Dr. Mitch Katz really understands the value of frontline workers and the expertise that all of you bring to the table. And this is what's so exciting about this process, that while we are engaged in this partnership and developing programs and working together, that there's also a respect for our employees, for our union members, for our union contracts, and that he absolutely understands that our contracts will be respected at the same time that we're developing this relationship. And that's one of the reasons that I'm here also, is I want to make it very clear to everybody that Dr. Mitch Katz and the union have a very clear understanding about, we will conduct business in terms of our union contracts. However, we all need to understand that patient care, the quality patient care that gets developed and delivered, is what's going to make us succeed. And if we don't work together through this in this unprecedented time, we're not going to be here. And so with that, I'm going to turn it back to Mitch so that we can continue this presentation, and there'll be time for questions. But make no mistake about it, we are fully engaged and prepared to develop this at every step and every level.
Thank you, Gilda. Thank you, Bob. So Gilda's comments are a perfect segue to hear from our colleagues at Humphrey. Humphrey Clinic has been involved in some incredibly exciting work about how to make the process for patients better. And I'd like to go with the success of our technology. Hopefully on my screen and on all of yours will now appear Humphrey talking about their tremendous work.
Hi, good afternoon, everyone. Can everyone hear us at Humphrey? Just maybe a hands up. Good, thank you. So I'm Alex Lee. I'm the Chief Executive Officer of the Ambulatory Care Network, the Interim Director here at Humphrey. So I'm really proud to introduce Michelle Clay on my right-hand side, as well as William Seguro, who is our supervising clerk and our registration staff, to kind of share the success story in terms of this theme of the partnership and also the collaboration to get our patients access to great care within the Department of Health Services and provided by staff here. So I'll turn over to Michelle and Lillian.
Thank you, Dr. Lee. My name is Michelle Clay, and I am the head clerk here at Hubert Humphrey. I'm also co-sponsor and co-lead for our CIT team. And basically what CIT stands for is the Care Improvement Team, and it consists of management as well as frontline staff coming together, meeting, and coming up with solutions to improve our patient experience. We meet on a weekly basis, and we discuss the problems with flow, communication between clinics, and during that conversation between management and line staff, we come up with possible solutions, which we call test of change. We implement small tests of change, and if it works great, we keep it. If it does not work so great, we come together again and then figure out what we can do to make that process better. And we have experience here at Humphrey that it really does work well. The frontline staff are the people who are directly involved in the processes, so they really are a great asset as far as inputting into the change process. The Gateway CIT project deals specifically with what happens with the patient before they get their vitals taken. And it deals with scheduling appointments, fixing insurance and impoundment, and the registration process. And we have 3 teams here at Humphrey: our impoundment team, registration, and call center team. Although Humphrey was the first facility to start with the gateway process, we do have other facilities that joined us. That was El Monte, Mid Valley, and Roybal. And then in the future, we will also be adding the other ACN comp centers. So Lily's going to talk to you now about our successes.
Thank you, Michelle. Hi, my name is Lillian. I'm a PRW, and I'm one of the CIT co-leads. Here at Humphrey, back in January regarding our phone access, in January, patients were waiting about 12 minutes to get to talk to someone and make an appointment. We have implemented a lot of changes and to support our operators, and now we've gone down from 12 minutes. We've gone down to 2 minutes and 20 seconds. So that's a big improvement. In registration, our patients, back in October, we were at 28%, meaning that 28% of our patients were coming on time for their appointment. Our goal is to have the patient seen within 15 minutes from their appointment time. So currently, we have came up from October 28%. Now we are at both of our our medical homes. We're up to 78%. So that's also a big improvement. We're registering our 78% of our patients on time. Thank you. Now, it was not just registration staff. We needed support. We also we engaged HIM, nursing, EVS. All of us had to work together in order for us to continue test of change, make improvements, and meet our goals. And we're still working on it, and we hope to even get a larger percentage with teamwork. We're very proud of the way we have improved our processes by working together, labor and management. And this is pretty much how our chart looks like.
Hope you don't mind the technology. It's a nice direction, at least.
Yeah, and the real payoff is the actual compliments that we're getting from the patient. We're getting a lot of compliments, and that brings us, even a smile to our faces. It makes us happier, and we have a much better environment, workforce. And it's very important that we are continuing to listen to each other and continue with our test of change. Thank you.
So that's incredibly impressive to staff at Humphrey. I mean, you've made a huge difference on key things, right? No one likes to wait for a long period of time to be seen. When people are registered ahead, it gets them seen on time because many of us as clinicians are aware you arrive in clinic and you're ready to see people, but if they're still in registration, then you can't see them, and so then you're an hour into your session, you haven't seen anybody, and then all of a sudden you're 4 patients behind and everybody is waiting. And so that's a really, really positive change, and I commend all of you. What I think we'd like to do at this point is go around to all of the sites so that we can all see each other and ask if people at the site have any suggestions, any questions, any thoughts about efforts that are going on in their clinic or their hospital, anything that they would like to see. Bob and Gilda, want to, learn. I want to learn. We want to make sure that together we're as responsive as we possibly can be. So will you take us around DHS?
Sure. This is Gerardo. I'm going to call on individual facilities, and I'm going to call them in the order that they're appearing on our screen here. So let's go ahead and start with Mid-Valley. And it looks like we have time for about 2 questions per facility. Why don't we start there? Any questions or comments from Mid-Valley?
Yes. This is Mid-Valley. We do have a question.
Yes, hi, my name is Pamela Contreras. I'm a nursing supervisor for San Fernando Health Center. As a nursing supervisor, we're getting a lot of questions from our patients regarding what is our plan for a backlog for specialty clinics. like the podiatry, ophthalmology, dermatology. I said there is a plan in place, but I was wondering how can I answer more clearly to our patients?
Sure. On specialty care, and I'd be interested as we go around others to note, we have through eConsult been able to dramatically shorten the wait times for a number of specialties. eConsult works so that I, as a general physician, when I have a patient who needs a service, so for example, I saw recently somebody with a history of cancer. If I had a question about what further evaluation he would need, if I had to set him up with an oncological appointment, that would have taken 2 or 3 months to get him into the system. Instead, I was able, through the consult system, to ask my very specific question about an unusual kind of cancer to an oncologist, who got back to me within 48 hours and told me everything I needed to do for this patient, including what laboratory work the patient needed, what exam. So we think that eConsult is going to go quite a distance. We know in a lot of areas we've been able to decrease wait times from what was once over 6 months to much more reasonable 2 to 3 month period of time. It's still very much in progress. It isn't done, and we're all learning. I'll tell you another story. It turns out that I never learned in medical school how to be a good photographer. I saw a patient who had a suspicious lesion on his face, and I hadn't been fully trained on the eConsult. I only knew that you could send pictures. So I took out my BlackBerry and I took a picture. And then I attached it to my eConsult, and the dermatologist gave me a stern warning about in the future I was to ask. It turns out we have dedicated photographers at the clinic that I work at Royville. I knew they were here, but I didn't know they were at Royville. And so, how to send a better picture so that they can really look at the lesion. So I'd say it is, as you were describing to your patient, it's a work in progress. The goal is to get all specialties up on eConsult, and then that will, over time, reduce the backlog so that those patients who really need to be seen. Give you just one more interesting data point. Ophthalmology, huge backlog. Using the new teleretinal scans, where a person in the clinic with minimal training can be taught how to photograph somebody's retina. 70% of the diabetics who got the screening with the camera needed no further appointments. You could tell just by the pictures that were read that their retina was fine. What they need is another screening in a year. At one time, all of those people would have needed an actual appointment. And what that will mean as all of this gets implemented is if you take 70% of the people out of the line, then the 30% who really need to be seen can be seen much more rapidly.
Great, thank you.
Thank you.
Do we have any other questions or comments from Mid-Valley? All right, well, thank you very much, Mid-Valley. What we're going to do is, because the boxes on the screen are jumping around, we do have another one?
Oh, I guess you saw it.
Oh, yeah.
Yeah, so we do have one more question. So you heard how great the teams are working at Humphrey and Mid-Valley. Similar things are happening, of course. And so this is all good because everybody is working together as opposed to working in silo. Everybody knows what everybody's doing and how it's affecting the other group and so on and so forth. So the question is, a lot of times there's concerns whether the information from the top, say from your office, Dr. Katz, is trickled down quickly and effectively and as efficiently as possible so that the teams can then get together and figure out what is the best way to address whatever's coming down the pipe. Can you talk a little bit about maybe some of the things that are happening at the top level that would allow information to trickle down to the facilities more effectively and efficiently?
Well, Well, I will, but maybe you or others on today's session will have suggestions. Among the things we've been doing that I think have been successful is a Fast Facts newsletter that we've been very consistent about sending out twice a month for the 3.5 years that I've been here. Then we have the bulletin board where people have been posting sometimes incredibly helpful suggestions. And then I come back and I go through them. We post answers where we're able to find the answers or suggestions on how to get it through. Then having this town hall, right, is now that we've figured out the technology thanks to our great IT staff, I feel like we have a venue. Let me ask Gilda and Bob if you would talk about, because the union is also a great way. Right, you have stewards, you have an organization of really active people who really care. Tell us more about how it works in the union.
So part of what we're developing at the union with our leaders is what we call conference room events, where we actually put on presentations on any new development. So that is going to be coming your way to the different locations here in healthcare, so that you get presentations from our perspective, from the leaders who are working directly in all of these committees. So that's coming your way. It takes a little bit longer for us, given our resources, but we will come out there. And part of this whole program that we're working with Mitch on also is about the leadership development of our union members. As part of developing and working in these committees, it's also about developing the leadership as it pertains to the role that you play with the union. Okay, so all of these things are going to be integrated as we work together and we move forward.
Great, thank you.
So we're going to make just a slight amendment here. I'm trying to pace the time here, or pace ourselves to the time remaining. And I'm going to go by the sheet that we had emailed, since the boxes are jumping around on the screen. So we're going to go to Building 10, followed by Hudson. So if Building 10, any questions or comments, please?
Yes, I'm going to have you talk to Pam Griffin, our project director. She would like to say a few words.
I'm hoping you can see my screen. Hi, this is Pam Griffith, and we are here, your ORCID team, and we're working very diligently to prepare the electronic health record for you. We've just finished our integration testing. So I'm going to open up the questions to our team here. If we have any questions in the room? Yes, we have one.
So we wanted to see if there was a way to be participant in some of those efforts where the earlier facility was talking about their ideas and their new ways of trying to minimize, trying to increase communication amongst the different departments. So is there an area, location, or website somewhere we can participate in a way so that we can kind of be informed as well? We would like to get some of those ideas as well to apply them if possible.
That's a great suggestion from today's meeting. Let's figure out how, and we've been doing some of this discussion with the union as well. We're trying to figure out, and I'm sure we'll come to you as the IT experts, on what a forum where we can keep people throughout the department aware of some of the great process improvements that are going on, so that we don't all reinvent the wheel, and we know that if something worked great at Hudson, right, that we can immediately take it over to El Monte and say, hey, Hudson had great success with this. Is this something you want to try at El Monte?
Adding to that, I just listening to this conversation, whether it's however we design the website, it should be accessible perhaps on the union website, the county, so that people could actually see this stuff. After this meeting, Mitch and I will have a conversation about how we might accomplish that.
Okay, Gerardo, take us around.
Okay, so we're waiting for the next tile to come up here. But I did say we were going to go to Hudson. We did say Hudson, and then I'm working with our Jason, so we'll go to Hudson, and then we'll figure out where next.
Hi, Hudson.
Hello.
How you doing?
Hi, my name is Rick Montero from Patient Services, and I have a question. What is DHS doing to try to retain loyal, satisfied patients with, to continue their existing primary care, that wish to continue at their existing primary care site, but have been reassigned through Medi-Cal managed care to another non-DHS provider who they have never seen before?
Right, so it's a good question. One of the challenges in the assignment system is that not everybody is equally able to open mail, read complicated, frightening government forms, make the right check. And so we've had, I know at my facility, Roybal, and I'm sure at Hudson, people coming and suddenly being told that they can't be seen. Right, and meanwhile, they've had wonderful care from the people at Hudson. We're working hard to, all of those people can choose to change their assignment, but they have to do it. We can't change their assignment for them. What we can do is help them to change the assignment, and I believe that the policy now allows us to see the person as long as they wish to change their assignment. So it should be such that if at Hudson somebody comes and says, "What do you mean? I've always come to Hudson," the next thing should be, okay, if you would like to continue to be seen at Hudson, you need to make this choice. If you're willing to change your assignment, then we can continue to see you. If you'd like to stay with your assignment, then you need to go to the medical group that's currently receiving reimbursement for caring for you. Is that generally working at Hudson? Is that happening?
Well, the issue here is that they're closed panels. So even though we have a loyal, satisfied patient that wishes to retain their services here at Hudson, we are unable to because of managed care putting a limit on our patients. So therefore, we're not able to make that change.
Is it that we don't, I know Dr. Lee and Dr. Parker are working hard to staff us up. That is to say, we're, it's a tough market right now for hiring primary care practitioners. So maybe hold on, and we will try to increase the staffing, which would then open the panels. Seems like that's probably the most efficient way. Great. Thank you so much. Thanks for all the great care going on in Hudson. I know Hudson, in terms of numbers, I think is the largest of the outpatient clinics. I just was looking at number of
Thank you, Hudson. We will now go to Roybal, followed by El Monte.
Go back.
Oh, back to...
Yes. Sorry.
Good afternoon, Dr. Katz. This is Dr. Shah from Urgent Care at Hudson. In light of the recent news reports of unaccompanied migrant children crossing the border, does DHS have a protocol for handling such children who present for medical care without a legal guardian?
I don't think we have a protocol, but what I would always say is that the great people in DHS will always take care of people and in the appropriate way. Obviously, there are laws around emancipated youth, but I'll again go back to say this is, it's always our responsibility as doctors, nurses, pharmacists, support people, to take care of people. And my heart goes out to those unaccompanied youth. And I know I would do anything myself as a provider. I want to take a minute because Gilda was telling me about some very important work that the union is doing to help support those children.
So next week, SEIU is doing a week of action to support the immigrant youth. And, I applaud, again, Dr. Katz and all of the healthcare providers that see these children and immigrants as people first. And I think that above anything else, we have a responsibility as human beings. Before anything, before the union, before anything else, we are all human beings. And I think about these children that are crossing the desert. And all I can say to you is that I'm going to take a stand for children. SEIU is taking a stand for children. Local 7 to 1 next week is the day for 7 to 1 to support the actions is Thursday, July the 24th at La Placita Olvera. We will be fasting. I personally will be fasting from Sunday till next Friday. I am going to come to work, but I will be fasting. Anybody who wants to join us on any of those days, we welcome them. If you can let me know directly at the union who will be fasting with us, that would be fantastic. But we need to take a stand for all children of this world, regardless of who they are. Thank you.
Thank you for raising that.
Okay, so I'm going to try it. Thank you very much, Hudson. And my apologies to everybody. We're going to make a slight amendment. We're going to try to limit it to one question per facility, and then time permitting, we can go back again for any additional questions. So Roybal, followed by Almonte. Roybal, please.
Yes, I have a question, Dr. Katz. This is for Dr. Katz, of course. We know that you're committed at the highest level on culture change, but my question is, how will you ensure that middle management is committed to the culture change?
Well, first I have to say hi to my home clinic. I was there yesterday. It's such a wonderful, Roybal is such a wonderful place. I really love working there. I've never worked in a clinic that I've enjoyed as much as Roybal. So thank you, everybody, for my own belief about culture change is that it's mostly about communication. DHS has had a hard history. And that isn't anybody's fault, right? Healthcare is a challenging field. LA is a challenging place to do it. There were really serious financial issues. The department almost ran out of money. We had a very painful hospital closure. And I think that took a toll on everybody. And I think that it made people afraid sometimes to do even what they knew was right. That there was just a fear generally of change. And I certainly experienced it when I came. People saying, you sure you want to do that? And the thing that I found has worked and that I see so much in DHS is that if we always put the patient first, how far off could we go? Right? If every decision is about the patient first, I feel like we won't make mistakes. And so I think that things are changing. And that part of our responsibility to each other is to support each other and recognize that it's difficult, and that especially if you went through particularly traumatic times in DHS, I can tell, and he'll laugh because he's here. Gerardo my first year, used to keep warning me. Are you sure you want to go down this road, Mitch? Right? We've lost a lot of directors here, and he was trying to protect me. And now he's always like telling other people, oh, I don't think Mitch will accept that. I think you're going to have to go further. Right? So, we all can, I think, appreciate that, we're in a much better place than we were. And DHS has always been filled with fantastic people. And hopefully the system will soon be as good as the people in it.
I want to add to that. So, one of the things that any time that we face change, it's very difficult. In this situation, we either can have change through a transactional way or through a transformational way. We are choosing the latter, right, in a transformational way, and that's going to take time. The way that we have, historically operated, even the union versus middle management with the employer, has always been in an adversarial way. And who knows, in the future, that may happen again, But for now, we all have to figure this out together. Middle management, our shop stewards, our member leaders, every single person at every single level. It's really upon us. every single one of us that has to engage and figure out how do we push through, how do we work through whatever challenges are in front of us. And I think that, like Mitch said, if we think about the patient first and take a step back, we can be reasonable. We can figure this out. And if we disagree on issues, then we have venues to figure out how we resolve problems. But it's going to take all of us to tango. It can't just be singularly.
I will say, I discussed this problem that we're going through, this transformational process on a national level. And although, I wish that we were further along all the time, I will say we have made more progress than the other large public hospital systems in this country. We have.
We want to take a comment. This will be our chance to hear from LACUSC.
It'll be brief, but I am just very excited about what I'm hearing and very excited about the spirit of transformation. And I, along with Fred and Anna and Diana, all people who are like seriously dedicated LACUSC employees, would like to publicly ask you, Ms. Milan, if you would meet with us around some of these specific issues. We would like to meet in the next week on a number of issues that have been ongoing at LACUSC. We really, really want to do, like Dr. Katz said, for the patients, the right things about this issue. So can we set a time to meet with you about some of these issues?
Of course.
Okay. When can you meet with us?
Well, I don't have my calendar in front of me, but
Are you committing publicly to meet with us by a week from today?
By a week from today, yeah.
Absolutely. Great.
Thanks, Isabel.
Great.
Okay, who's next?
Next is El Monte, followed by Harbor.
Okay, we have one question from El Monte.
Where's El Monte?
Good afternoon. Over here. Good afternoon. We currently have a DMH, a mental health co-location at our facility. What other initiatives is DHS working on with other county departments?
Excellent question. So the one that's going really well with public health is we're going to be able to soon use e-consult, and it won't have to be a physician, to get substance abuse services through the Department of Public Health. So basically what we will do is when a patient needs substance abuse services, we will be able to ask them for a specific placement of an outpatient or a residential substance treatment physician. Up until now, what we have had to do is basically call around, and it's been very difficult and very time-consuming. So that's one part. Social services, has been a great partner in getting our people enrolled, and we may want to look at in going forward, the placement of more people who can actually enroll people from our site into Medi-Cal. So lots of good things happening. We're lucky to have a great county family. Thank you.
Thank you.
Thank you, Almonte.
Thank you, Almonte. Now we're going to Harbor, followed by Long Beach.
My name is Sheila Mitchell, and I'm the Assistant Administrator over Patient Experience. And I'd like to say hello to everyone. Harbor is in the process of developing a very robust patient experience program, which includes the incorporation of managed care standards across the facility. And when implemented appropriately, we believe that this will be beneficial to both the patients and the staff satisfaction. So that is one of our goals that we plan on implementing as soon as possible.
That's great. Harbor, I want to tell you that Gilda and Bob and Patricia and all the union looked at the great video that Harbor made on the eye clinic and how Harbor, transformed its eye clinic to shorten wait times, and it was really brilliant work. Second, I want to say that I've already been in conversations with the county about a new hospital building and the possibility that we can help to build a new Harbor inpatient site before the 2030 deadline, because we know that the 4 bedrooms, especially around privacy, around infection control are very challenging. We love Harbor, for everybody to know, did a phenomenal job moving in to the surgery suite and the emergency room. It was, I think, the most successful, efficient move-in I've ever seen. It was a very difficult. And then on a personal note, just because I already made the schedule, so I will be at Harbor October 15th through the 31st with a holdover till the 2nd for the Orchid on the inpatient medicine service attending. And I chose deliberately that transition from the old system to the new Orchid so that I could be there, when we're struggling along with everybody else, as Harbor leads the way on the new Orchid system. So I'll see you on the medicine wards and rely on you all to help me get through my patient rounds. Thank you.
Thank you, Harbor. Now on to Long Beach.
All right, Harbor. Yeah.
Hi, Dr. Katz. My name is Paul Revelar. I'm a registered nurse. I work here in inpatient psychiatry. Questions regarding safety. Here at Harbor, over 90% of psych staff have signed a petition. We are concerned about the increased number of injuries in 2014. They may or may have not been reflected in the OSHA logs. Our question is, when will we get a response to our main request? That there will be a separate code 3 team created, that there will be a safety task force with staff created on it. We have been waiting since May 15th for a formal response and want to be safe in our workplace.
Well, thank you for raising it. It is an extremely, PES is an extremely difficult place to work. At Harbor, we've also had issues at all of you at LAC USC. And we are committed to changing and making those facilities safer for patients and for staff. Among the things that we're doing, first we're working on creating an urgent care that is in the Long Beach area so that you can be decompressed in number. Because I think that just the sheer number of people coming through your PES at Harbor, and the same is true at all of you, makes it much more risky for the staff. That if we could have fewer people there, it would do better. Then we've had very productive conversations with the union, and I know Del Vecchio is working on increasing the staff and coming up with a model that would put more staff to protect safety and have a better response. I've talked on the safety issue with both Del Vecchio and Kim McKenzie as well. So I'm sorry it has not been as fast as I would have liked it to be, but we are committed to it. And I know the union as well. This has been an important issue for the union.
Absolutely. I know that Mario and Patricia have been leading the effort in this area. So I'm sorry I didn't have a briefing on this before today, but I do know that we are working toward this, and I'm happy to hear that Mitch Katz is saying that Del Vecchio is working on increasing the staffing there to begin with, first of all, cutting down on the amount of patients that you yourself are seeing. And so we will get an update on that and follow up from here. Okay?
Thank you, Harbor.
Thank you. Thank you.
Thank you all. We're going to try to get to 9 other sites, and we're trying to make sure everyone has some input today. So if we could limit it to one question or comment, we would really appreciate it for now. Long Beach, followed by all of you, please.
Hi, this is Toy Bond, Assistant Administrator at Long Beach, and this is the Long Beach staff. Our question is, how will the union be involved in the Orchid implementation? We're the first outpatient site to go up, so we'd be curious about that.
Our involvement with Orchid. Oh, so we've been...
Wait.
Hold on a second.
Wait.
I'm going to have our healthcare director respond to this, because I don't have the latest information on this one.
So hi, my name is Patricia Castillo, and as far as the Orchid,
one of the involvements that we've had is we have a workforce development training program, and in the workforce development training program, one of our focuses was making sure that basic computer skills. Some folks have never used a computer or aren't familiar with the technology, and so one of our first things that I think we were able to accomplish as far as in preparation for the ORCID in conjunction with workforce development is basic computer training for our members, and we've done that collaboratively. Over 8,000 people were trained all across, in particular in the target areas where it was going to roll out first.
Do you want to tell us anything about how it feels at your ends? Everyone may not be aware because we harbor, when we say harbor, it's harbor and the ambulatory clinic. So how does it feel at your end in terms of the ORCID implementation?
I think the staff are anxious to see what the product looks like, and we are ready to transition over. I think the communication would be nice to have for all of the different modules, because we really haven't seen a full product yet, but I believe training is going to happen in a couple months. So hopefully by then we'll be able to see the full product.
Right. One of the issues about the training is that we've learned from other systems they recommend you do training very close to implementation. That's right. Because apparently other people have found if you do it 3 or 4 months ahead, you have to do it again. So I know it might feel tight, but this is what the field recommends. Anyway, nice to see you all in Long Beach. Thank you. Okay.
Next, we'd like to go to all of you, followed by High Desert, please.
Oh, yes, hi. Thank you for your time, Dr. Katz. My name is Joseph De Leon. I'm a PRW at Outpatient Financial. And before I ask you my question, I want to piggyback on the earlier you said about the culture. My question pertains to, I had an opportunity to interview about 28 of our members here at All of You, and I asked them about the culture of management. So my question, or our question to you would be, can you give me your input on how to change the culture of an old management way of thinking and processing? Because we're always, let me give you an example, and I might sound a little nervous, but I am. So excuse that. A perfect example I want to share with you is what some of our members brought up with the culture about management. When it comes to our PE, our evaluations every year, is that members are concerned that they feel that they go out of the way, they put in 100%, 120% to make a difference here at All of You. But when it comes to our evaluations at the end of the year, it seems that we always end up with a competent, never an outstanding, never a... So changing culture in the process of morale, changing culture and being approaching management a little bit easier with our concerns.
Understood. Openness to me is, one of the things that matters the most. Being, not rigid, being willing to hear different perspectives, being willing to think how things are. People who come to work at DHS overwhelmingly are phenomenal people who come for all of the right reasons. And sometimes, somehow, our system doesn't fully appreciate the amazing work people do. I want you to know I certainly appreciate the amazing work that people at All of You and other places do. I recommend our facilities to others. I think that the quality of the care is phenomenal. And I will keep working with our managers. We have great managers as well, but sometimes there is, the managers themselves have sometimes come to me where they thought they had limited choices, where they weren't aware that there were ways to change things. And I think it goes back to an organization that went through some hard times, and that it's hard sometimes for people to fully relax and embrace the fact that we currently are not in a budget deficit, that we currently, are doing well at recruiting people, that we are actually decreasing wait times, that it's hard if you've been in the system for 20 years, where people were constantly telling you, as in management from the director's office, either you can't do that or we don't want you to do that. That has an impact on people. But I'll take your comment and the earlier comment, to heart, that I need to think about ways that I can make people feel that they can make the kinds of positive decisions and positive evaluations that you're talking about.
Let me add to that. So this is a perfect issue, right, of where there needs some focus and attention, okay? There's disagreement on the way this is being handled, obviously, right, because our members are not happy. And so this is a perfect area for us to figure out how we're going to work through this, challenge that's impacting our members, okay? Perfect example for us to follow up and figure out how we fix this, okay? Because at the end of the day, in the spirit of the work that we're doing together, it's not about making people feel bad or pushing anybody out or making them feel like they're less worthy on their evaluations. We got to work through this and we got to fix it. And I think, again, you hear the commitment from Dr. Katz that we will figure this out. So, okay?
Thank you, all of you.
Next, we're on to High Desert. High Desert followed by Rancho. High Desert, please. Question.
Are you in the new
Good
building?
afternoon.
Are you in the new
Thank
building,
you.
High Desert?
Very nice, thank you.
Greetings from the new High Desert Regional Health Center. We have one question from Dr. Wadi Tadros.
Good afternoon, Dr. Katz.
Good afternoon.
In your last newsletter, you said we impaneled over 385,000 members. I have a two-part question for you. Where do you see us in 5 years? Second part, are there any plans to contract with other HMOs besides HealthNet and LA Care?
So yes, our goal is to expand primary care. We have additional positions. We're currently filling them. As we have additional practitioners, we'll be able to push up that empanelment. I think that a reasonable goal would probably be 450 to 500,000 in terms of what we might be able to achieve. And that will enable us to expand contracts. Part of our limitation at the moment with contracts is that most of the plans want the whole service line. They want primary care and specialty care and hospitalization. It generally is much harder to get them interested in just a specialty service. So if we're able to recruit those practitioners, I think we can then expand our panels. We love your new building. It's beautiful.
Thank you.
I think if anything would bring people, that the combination of the building and the people at High Desert will. Thank you.
We are already seeing an increase in numbers.
I'll bet. You have a fantastic staff, and now you have a fantastic building.
Thank you so much.
Next, we'd like to hear from Rancho, followed by Ferguson, please. Rancho, please go ahead.
Hi, I'm Lavesha Floyd, Marketing Analyst here at Rancho, and our question is, how does leadership view the relationship between patient experience and staff satisfaction, as well as what plans do you have?
Okay, well, so I believe that people at DHS come to work because they want to make a difference, right? Healthcare, attracts those people who are genuinely interested in caring for other people, making their lives easier and better, and that's true whether you're a doctor or a registration person. Everyone comes to DHS, I think, with that idea. I think part of the problem in morale has been traditionally that people have seen a system that was broken, right? So you want to deliver good care, and you're the registration person, and the person you're seeing is incredibly angry because they've been waiting for 6 hours. And so they're rude to the reception person, which makes the reception person upset. And besides, who wants to work for a failing organization, right? Who wants to come to work knowing that everybody is waiting a very long time. And what's interesting is during all of these difficult years, the quality of the medical and nursing care that people got when they actually got in has always been high. That's never been our problem, DHS. DHS medical care, nursing care, pharmacy care, very high, way above community standard. The problem is getting into it, right? The phones that weren't answered or that were answered so long after. So my belief is that as we improve the patient experience, and patients are grateful, right, that they got great care, and then people who come to work then can feel that I'm part of this wonderful thing that's providing great care, and people are not upset with me anymore, but they're pleased because they're getting such great care. So I think that when you're a healthcare provider, right, we don't make anything, right? We're not a factory. We don't have widgets, right? We're people. All we have is ourselves. That's what we deliver. And so if our morale is high, we're going to deliver a great product. If our morale is low, we're going to deliver a mediocre one.
Yeah, I think that in the spirit of this transformation, and again, I just want to reiterate, and you're going to hear me say it over and over again, this doesn't happen overnight. And while we realize that, we've been rolling out ACA here for some time now, we have been engaged in discussion of even, our own education programs that we have available through the union of what we can do to be available and participate in developing the relationship building part. Because even, anytime that you welcome a patient and you're the first person that they see, how you respond to them sets the tone of how they're going to act the entire time that they're there. And so just those little things of how you interact with people, if you smile, if you make eye contact, those simple things make a difference. And so again, part of what we're trying to do is figure out all of the different areas that we can be of assistance to help figure this out, including the issue of morale. Because you're right, we can do all the trainings, we can do all whatever. If you're not feeling it and your heart's not there, it doesn't matter how many trainings we put people through.
We should mention about Rancho that one of the great things about Rancho is its patient council. That Rancho, has really taken the furthest, journey into how, the people we're here to serve feel about the care that we're giving them. They have a very active patient council. People come back after they've been at Rancho and talk about the things, and Rancho takes, that input very seriously and makes program changes. So thank you, Rancho.
So next we're going to go to Ferguson, followed by King, please. Ferguson, please go ahead.
Good afternoon. Presenting a comment question on behalf of us here at Ferguson. First, I'd like to say, Humphrey, congratulations on your successes with improvement in wait time.
All right, Stephanie.
We're back. All right. We still muted?
No, we're not.
Hey, Ferguson, we're not able to hear you. Can you try to speak a little louder, Ferguson? Still cannot hear you.
Okay.
We
working out. Can you hear us all right?
We can. Speak loud.
Okay. Not a problem. Once our patients are informed of the transformation, how will we communicate this to our patients?
Okay, so the question is how do we do a better job communicating with our patients? That's a great question. We haven't done much so far with that. Most of the communication has been via managed care. And of course, when people get great service, they tell each other. But I think that's a great suggestion, and we'll look into the question of how we do better in talking to our patients about the great success of DHS. Should we go? I don't want to miss King.
King, please go ahead with your question or comment.
Yes, this is Roxanne Welver, and I'm one of the PRWs here at the new MAP, and I'm also on the CIT committee for hemo-oncology. And my question is this. is that I've noticed, first of all, I've noticed a very dramatic decrease in the amount of patients that we are seeing in our clinics. And that causes me a great deal of concern. And I started thinking about it, and one of the things that happened to me earlier this week was a call was transferred to me, and it was a patient who wasn't my patient, but needed a service taken care of, and it dealt with the Central Appointment Center. And it took me almost 30 minutes to get into our Central Appointment Center with this patient. And my concern is twofold. Number one, that my clinic does not have confidence in our Central Appointment Center. And this is being expressed both by, and we're not the only clinic that is feeling this. And my concern is, what protocols do we have in place so that when these patients drop out because they have three-month appointments, 6-month appointments, and the specialty clinic at discharge cannot schedule that person's appointment, what protocols do we have in place? And it seems like we're losing patients to follow-up, and we need to address this.
Well, thank you for telling me. I wasn't aware that that was an issue, and we'll immediately look into the centralized appointment system. Obviously, in order for us to retain our patients, they have to be able to get a follow-up appointment. It's a very basic thing, so we will work on that. Thank you for raising it.
Thank you very much, King. We'd like to get input or comments from managed care in Alhambra, please. Alhambra? Yeah. Alhambra, your question? Oh, we can't. Is your microphone on? We can't hear you. Still cannot hear the speaker. There, we do have 313 that's on. We want to go there.
Okay, hold on, Alhambra. We'll come back.
We have 313 Figueroa, and then we'll go back to Alhambra.
Hi, this is Rowena in the Government Relations Office. Does anybody have any questions? Going once? Going twice? Hi, Mitch. Sorry, we don't have any questions right now.
Okay,
We're enjoying all the questions everyone's answering.
Over shortly. See you soon.
So maybe we can go back to Alhambra managed care and see if we got the sound working there.
Can you hear us?
Yes, we can. Please proceed.
Okay, the question we have here in Alhambra is whether or not there was a strategic plan in place to consider incentivizing some of these programs to improve the patient and staff experience, maybe incentivizing productivity, incentivizing facilities if we're able to meet certain benchmarks for timely access.
So the question is about incentivizing. I don't know if people are thinking of specific financial things. I mean, my own belief is that people come to DHS not to earn the highest salary, because if you were trying to earn the highest salary, you would have chosen a different place to work. And people come here out of mission, and that's then the thing that we most should capitalize on, is how many great people come here really because they want to provide fantastic care to patients. I do think, though, I'm a big believer, but I don't particularly like individual compensation stuff. I do like, and I think we should do more of, like we've done before, some sort of healthy competitions where clinics or hospitals might get something for their patients, or some needed piece of equipment as a reward. So I believe in sort of prioritizing and incentivizing teams and clinics and or hospital programs. So that might be something that we do. But I don't see us in the more transactional private sector. And to be honest, if you look at the literature, it doesn't show even in the private sector that it works the way people think it does. That sometimes if you pay people to work on one thing, they stop working on something else. So I would rather we lead on our mission.
I have a comment on that note, sort of, if it's okay.
So let's have we done all the?
We've done all the facilities at least once.
Okay, so we're at time. What I'm thinking is let's say goodbye to everybody because we're
We need Humphrey. Humphrey has a question.
I figured since they presented. My apology. I figured since we did not get a question from you.
Just hold your question for a second. Humphrey, sorry. Come back to us. Go ahead.
Okay. My name is Patricia Guillory, and I work with the patient relations at CIT. I'm the supervisor in the cashier office. My question is, would managed care consider journeying with Covered California? Because we have lost a lot of patients that has Covered California and can no longer continue their health care here, but they want to come here. So we have to tell them that we do not accept Covered California. So I'd like to know when you will consider that.
I think we're going to do it. It's just because we were so behind in our managed care infrastructure, and we had so many people coming in through Medicaid that we needed to make sure that we didn't fail on the Medicaid. If we had failed on the Medicaid, the future of this department would have been very bleak, and we did succeed. And so it's just a question of, when. But I think certainly within the next year, we will be able to accept the Covered California. And it's not only that we lose patients, but our patients go in and out of the workforce. So one moment they might be Medi-Cal, and the next moment they're Covered California, and the next moment yet they're back on Medi-Cal. So part of why we need that Covered California, so we can keep them. Okay, thanks for coming back to us, Humphrey. So we've been to
all the facilities.
So you tell me, is it better? Should we let? I don't want people to drift out. I'm going to stay. Can the two of you stay? There are other questions in this room we can do. Should we?
We got an extension on time from ISD. So those who are interested could stay and listen if they'd like to.
Okay. So here's what everybody. We're going to dealer's choice out there. We're going to say the three of us are going to wave to you. If you have to go because you have to go, go ahead. We appreciate that you were with us for this. We're going to stay another 15 minutes or so and talk about questions that are in this room. We love your company, but we also understand if you have to go, okay? So thank you, everybody. We really appreciate you being part of this. Okay, so you had a question. We'll capture everybody. We're okay on time.
Okay, so my name is Diana. I'm with Patient Financial Services and the Customer Service Liaison. Part of what we've been experiencing that deals with incentives monetarily is we're very short-staffed in the emergency room. And we will hire PRWs. The problem is no one wants to work graveyard shift. And we know that the nursing department does get higher compensation for that. When I called to schedule interviews for PRWs, everyone wants to come in. As soon as they hear it's ER graveyard, they're like, no thanks. So it's very important to, the wait times of ER, financial, frontline staff. I think somehow we need to be able to compensate so that people stay working the graveyard shift for a year.
That's a great suggestion. You have two union leaders. How's the best way to achieve that?
There are ways to achieve that in negotiation, and we should look at those. Because as we all know, the last contract was only a 2-year contract, and we'll be back at the table next year. So we should actually look at that in bargaining. It's very important. I have some ideas, but we should have an internal conversation about that.
I mean, the other thing is too, me and Bob, and we could talk about this afterwards. If the urgency is such that you can't staff there, then we got to figure something out sooner, right? So one will be bargaining, like Bob said, but the other thing also is if we can't staff because people don't want to work there because of the lack of compensation, then that's a different issue.
Maybe it could fall under the workforce shortage.
Sure.
Okay. All right. Thank you for that suggestion. Go ahead.
Hi, hello. My name is Christina Martinez.
Hi, Christina.
I'm one of the cardiac care coordinators here for LAC-USC. CCU nurses as well as myself, we've been seeing a lot of patients that they come in and out for CHF exacerbation. And what was brought to my attention, if we could possibly set up a program for our heart failure patients. We have nurses that are eager to teach, and if we can develop a program for them. We have also attendings that would support us with this. It would be great if we could now provide this for our patients.
It's a good example, and we were talking yesterday with our union colleagues about nurse-run clinics. And a CHF clinic could be an RN-run clinic because diagnosis is set, and you can set parameters for weight, blood pressure, and have people make recommendations with a physician who's available for consultations. It's a great idea. We'll look into see if we can do it.
Thank you.
My name is from HIM. I'm a code. Now with nurse practitioner in your system, it doesn't take nurse practitioner as a provider. I have to put a doctor in there. So we need a doctor to co-sign those orders and those doctors. As a coder, I have to put physicians in. I cannot put nurse practitioner. I know a lot of nurse practitioners on documentation, but I cannot put them in the system because they want a physician provider.
We understand. We'll make sure that's part of it.
Yeah, and also how when organs going to be implemented at this facility.
Does anyone know Orchid here at LACUSC? It's somewhere in the middle. I don't know.
Roger's right there, and Dr. Gruber, I believe it's May 2015 is our tentative
our
date.
goal might be for working at LACUSC is May 1st, 2015.
Thank you, Dr. Gruber. Nice to see you.
Less than a year then.
Yeah.
Okay, how about this side of the room?
So, Frederick Ochoa, I work here at LACU for with utilization review. We've heard a lot about partnership, and I think, in getting things done here, if we're going to be partners, we have to be seen as equals, and we have to work together. And that demands some respect. Respect, I think, for what some people have brought up, were our contracts. We have many issues, as Robin said, on the table that have been on there for months and months and months and could have been resolved. It's eating up a lot of time on my part and having to be there for the grievances. Management's part to be there on the grievances. One of the things we need if we're going to be partners and develop morale is have that respect for our contracts that are legally binding contracts. There are issues in there that have clarity and management, again, at upper and middle management continue to go against the grain of the contract. That's one thing. The other thing is we're getting 700 new positions for DHS. That's awesome. That's going to take care of an issue that we've had going on for many, many years. But now, with the 385,000 new people that we have in, we're probably going to need even more people. And not only that, the infrastructure, the resources that we need to process people through our systems. Education, working with workforce development to get more nurse practitioners, nurse anesthetists for the ORs. The ORs are very backed up. These are things that we need to take care of. And what are your thoughts on this?
There's a lot to do. I'm with you, Fred. There's a lot of great work that's before us. The 385 are not necessarily new people to us, right? What that represents is DHS's commitment to impanel patients to a specific doctor or nurse practitioner or physician assistant, because we know that when it comes time to choose what plan, people care about who's my doctor, who's my nurse practitioner, and so on. So they're not new. That being said, because we have been successful, and I want us to continue to be successful, that's what gives us the opportunity to hire more people. We've been having some success at speeding things up. For the first time, our Department of Human Resources did a job fair. All the hospitals sent, was the first one the RN or the LVN?
LVN.
The LVN they did first, and the RN is next week.
Monday.
We had all of the nursing directors send someone who could make job offers that moment. I think they made 75 job offers at the LVN event, and they marched the people off to do their live scan, which normally is a call, Fred, are you there? Fred's not there. He calls me back the next day, then I'm not there, right, until we get it scheduled. So, I'm with you. I mean, I'm very proud, Fred, of what we've gotten done in the last 3.5 years, but there's a lot more to do. I always viewed, the transformation, in my mind has always been a 10-year project. And I'm really happy where we are, as I see it, in 3.5 years of, from the, but there's a lot more to do. And it isn't easy, and DHS is a huge organization. There's a lot of DHS law about what you can do and what you can't do, and sometimes it's true and sometimes it's not true. Some things that people feel are clear in the contract and are clear on the contract. Somebody, for whatever reason, has never read the contract and they have some completely different idea about it, right? And it isn't true, and the contract has to be respected. But somehow, as an organization, we also have to work through these issues, right? We have to figure out how we work, productively together. Bill or Bob, do you want to say more?
Do you want me to respond?
Well, I want everybody to know, one of the things when we ventured down this road, a lot of people were worried about, accidentally making mistakes in this process and overriding the contract. We actually have language in the agreement that can't happen, okay? But that being said, okay, we have to find ways to deal with the problems that exist so we can deliver the product that we all want to deliver at the end of the day, and that's important. And we have to be mindful of both aspects of this.
So, and just to add to what Bob said, I've been with SEIU for almost 30 years, okay? And when I first joined SEIU, we talked about transforming the organization into this organizing, model where we would grow the union, et cetera, et cetera. It's been almost 30 years, folks, and we still work at it every single day. So I'm happy to hear that you can get this done in 10 years, Mitch. But the truth of the matter is it's going to take work, and it's going to take work every single day. Okay, and I just can't tell you, how many times I'm going to say this to you, is we're going to, yes, we have to deal with the backlog, Fred, absolutely. We should make a list and figure this out, because I'm not a believer in just let things sit and brew. We've got to tackle it, okay? But again, it's going to require, patience. It's going to require everybody to get involved and to be part of the solution. Because it's great at making the list of all the things that are wrong. It's like everybody can make that list, but who's going to, be part of also figuring out how to resolve it, right? And that's what we're asking. It's like everybody's got to jump in and be part of the solution, okay?
So, Ileana, oh, okay. For those of you who don't know me, my name is Ileana Mesa. I know Dr. Katz knows me.
Nice to see you again.
Good to see you again as well. I just wanted to piggyback on what some of the people were saying in terms of the morale issue. And I know that you will take this to heart and really look into it. And Isabel, since you're here sitting right next to me, I would like to know, are the managers trained, or do they ever look at the contract or the MOU? And I know, we have really good nurses. I work in the gynecology and oncology clinic, and that's a really hard place to work, if you guys know. I mean the patients, we get patients that are dying and stuff like that, and our nurses work really hard. And again, like the gentleman was saying, that they can only get competent, and I have actually heard managers tell me, I cannot get a very good and I cannot get an outstanding because the county won't let me. So I think we need to start by finding out who is the county that won't let me. And I would openly share a personal experience that happened with me. And last year when I got my performance eval, the director of the Division of Oncology, who's my supervisor, Dr. Linda Roman, she gave me a very good, and when it got to administration, to the area administrator, Rose Lascano, she goes, no, you have to change it. We cannot give very good. So my supervisor and Rose went through this 7-month debate. And my supervisor's like, you don't know her. You don't know the work that she does. What does she do? And the area administrator's like, I don't know, but I can't give no one can get her very good. And this is what everyone is told. All the nurses over there are told, you can't get a very good or an outstanding because of the county. So we need to find out who is the county and who in management is saying this and why is it happening, because I think it could be a very easy problem to solve but in my case, my eval was told by management, the area supervisor, because there has to be 4 signatures, the division head, your supervisor, and the area administrator, and she's the one who said you can't do it. And after the debate, of course, I got my very good, but that doesn't happen to everyone.
Right, and it's not a good use of time. And there is no rule. There is no rule. So I have no idea.
Okay, you guys say that again. Can you have it right?
It's on YouTube. It's on YouTube.
Rose looks kind of cheap.
I would never support that.
So we have a question back here.
Get very good.
We have a question back here and then back over to.
Hi.
Okay, we got 5 minutes. So.
Hi. Mine is real quick. I'm a financial service worker. I'm inpatient, but I work overtime in the ER.
Thank you.
And my problem I have is a lot of our poor patients that do not read or write, when they go mainly to quick reg, their papers are blank. And you know, it does slow up the process, but we do have to help them fill it out.
Right.
And my thing was to suggest, hopefully, but I don't know if it's possible. We do have a lot of volunteers that like escort the families back there. Maybe they can assist some of the patients, because sometimes the patients will ask strangers, you know, and this is their personal information on there. So that is one of my concerns for those patients that, you know, do not, and they don't have family with them.
Well, go ahead. Okay, one.
Is the pharmacy really time
then
better?
we'll come back to you.
Go ahead.
And I do us.
Patricia, and
I have a question.
I'm an employee here at LAC, and I'm.
My
question deals with the practice of pay for performance bonuses. We have some managers who use their items. They don't promote people, but people are doing work. They don't call people, they don't promote, because they use the salary savings as a means for their pay for performance bonuses as part of it. And what I want to know is can that be looked into? Because I have no problem with a good manager getting a bonus, because I know I like bonuses, you know? But I have a problem with someone who's working someone, refusing to call tests, refusing to promote people who deserve it, so that at the end of the fiscal year, they'll have money, salary savings, and a bonus, you know.
I understand what you're saying. We don't support that practice. Okay, photographer has the last question.
Is pharmacy,
Then we have
pharmacy wait time better or worse?
I'm sorry, pharmacy where?
Wait time.
Wait times are way better where there is the refill.
Okay.
So if
There's been no change in the pharmacy.
Right, you don't have
rate
refill.
at LACUSC.
Yeah, you don't have the refill yet, but you will. So what the refill is doing is enabling the pharmacists to focus on the new prescriptions. So where we've been able to do the refill, we've been able to shorten lines. But where we have not, and LACUSC, we have not yet done the refill. Not yet. Okay, everybody, listen, this is not the last one. I'm glad that people come out. I'm glad that people have so many questions. That's all really positive, and we'll be out here doing it again. So thank you all for coming today.
Thanks, Jason.